All right, so I am preparing for my internal medicine and a rotation exam. So this rotation starts tomorrow. I figured I'd get a little bit of a head start here. So there's, I don't know, probably 10 categories of topic lists. The first one is pulmonology, so we're just going to start there. This is the list I've been given. So we have 21 topics. I have reorganized that into obstructive lung disease, restrictive, infectious disease, malignancy, pulmonary emergencies, and miscellaneous pulmonology. So we're just going to dive right in. And the first one's going to be asthma. So asthma is going to be first of the four really obstructive lung diseases. And by obstruction, if you think of the alveoli, you have this kind of like ball valve effect. So you'll have, an obstruction here, whether that's like mucus, it's normally like a mucus plug or something. You have this increased bronchuria, bronchial secretions. When you inhale, that plug is going to go in and will allow air to get into the alveoli. But then when you exhale, then the plug is going to plug back up and the air is going to be trapped inside. That's why it's called obstructive lung disease. Okay. Viral infections are going to be kind of the number one trigger here. And I think viral because viral URIs are so common and asthma is very common. So you can kind of marry the two together. Some triggers here for asthma. So GERD is a big one that you might not necessarily think about. Obviously, like sinus disease. And then you have aspirin and NSAIDs. And I was kind of looking that up a little bit. Looks like aspirin and NSAIDs, they inhibit cyclooxygenase, which can normally help with some inflammation and pain. And then there's also an effect in the metabolism of leukotrienes. And you look at a medicine like Singulair, which is montelukast, which is a leukotriene modifier. So that makes sense there. All right. Occupational, obviously. So look for like improvement on the weekends. If you're working around chemicals or outdoors or something and you keep having these flare-ups, but when you're at home, you're better, then it's most likely asthma. You can also have nocturnal asthma. Always questions you want to ask. These are always big ones. Hey, have you ever been intubated before? Have you ever been in the ICU? Because even though your patient might appear stable in the ER, what's the worst case scenario here? This can get out of control pretty quickly. If they have a history of this stuff, you want to be ready. You really want to be prepared for the worst. Okay. So knowing what forced vital capacity is definitely important. If you look at the bottom here, this dark blue part, this residual volume, you can't physically get that out of your lungs. The interesting thing is if you exhale and then exhale even more, you're still not touching this dark blue part, When you breathe in and you breathe out, that's your tidal volume. When you breathe out and then again, that's your expiratory reserve volume. Okay, that's what you're breathing out. But what you want to know, what the important thing is yeah, your vital capacity. What is your total amount of usable air in a full breath? This tidal volume is just like a normal breath. But when you fully inhale, this is my orange, fully breathe out so you don't have anything else left. That's going to be this purple part plus this little blue part. That is your vital capacity. Okay. Definitely a good thing to know. FEV1 over FEVC is always going to be the measurement for, how bad is this asthma? How bad is this COPD? Not everybody needs a chest X-ray. You're going to have episodic attacks, and a severe attack, they always say might be silent. And what they mean by that is that there's like no air movement. They might just be kind of sitting there, but they're not moving air at all. It's silent. So this is always something that's generally tested upon. And really, if you have to memorize one, look at mild persistent. Okay. You're still having symptoms less than 2 days per week. Um, but you're using your SABA like albuterol greater than 2 days per week, but not daily. And you are waking up between 1 and 4 times. So moderate persistent, everything is daily. So daily symptoms, daily use of SABAs, that's going to be your big key here. And then not daily, but weekly nocturnal awakening. So it's not per month, it's per week. So know that's moderate persistent. You know that, intermittent, mild persistent are still symptoms less than 2 days per week. But the Sabi use here, that's going to be your clue that's going to bring you up to mild persistent. Okay. And you think about this, that, these three persistent is going to be, well, it's persistent and it's just mild, moderate, severe. So you can look at those as a triad and then think about intermittent. Most likely you're not going to be asked about intermittent. It's probably going to be mild or moderate. Okay. We'll talk about the medications in a second. I don't know that this is that important of like what they need to be on. More likely you'll be asked on how to how to qualify this. Okay, so let's talk about medications here. So you definitely want to know really the names of what these categories are. So know that a SABA, a short-acting beta agonist, is albuterol. Graduating up to the bottom right in the middle here is a LABA, a long-acting beta 2 agonist, and that's going to be like salmeterol or formoterol. Okay, so you have albuterol that you use for a rescue medication. That's why you have this little rescue thing here. And then you move up to a controller, which is going to be long acting, which makes sense, right? Something that's long acting is going to be a controller. Now we can also look at the short-acting muscarinics, which are these parasympathetic antagonists. And you think about this, and you think about parasympathetic is going to be acetylcholine, is going to be cholinergic. That's where we get into when you think about toxicology from the emergency videos that I've done. That's your killer bees. That's your bronchorrhea, your bradycardia, your bronchospasm. So that's parasympathetic is doing that. Cholinergic is doing that, acetylcholine. All of that is attacking your respiratory system. So if we use a parasympathetic antagonist, we're fixing all of that, right? We're fixing all of the killer bees. And an example of this would be ipratropium, which by itself is called Atrovent, but most likely you're going to see this in what's called a duoneb, which is going to be ipratropium and albuterol. So you're combining the SABA and you're combining the SAMA. You are agonizing beta 2, which for the most part is going to bronchodilate, and then you're killing the killer bees by using a SAMA. Okay. All right, so moving on, this you can use either as a rescue for COPD, or you can use this as a controller for asthma. And these are just going to be your systemic steroids, right? It's your prednisone or prednisolone or methylprednisolone, which we use in the ER via IV. Okay, you always want to make sure you taper these off so you don't cause a secondary adrenal insufficiency. And some red flags here. One of the things that I feel like is asked commonly is, a patient coming in with an asthma attack is probably going to be tachycardic. And when you give them something like albuterol, a beta agonist, which like epinephrine is a beta agonist, it's going to make them even more tachycardic. You could see it here. It's this limiting factor, but that's fine. It's the limiting factor. Their their heart rate is increased because they can't breathe. So you're fixing that problem, so you don't really want to worry about that tachycardia. You don't want to let that limit your management. Okay. The other type of steroids here we have are the inhaled corticosteroids. So examples here are fluticasone, beclomethasone, and budesonide, which is Pulmicort. So here's the thing. You want to rinse your mouth out to prevent oral thrush candidiasis. This is one of those things that I feel like in P1 year, you hear the stuff so often, but it's so fast paced, you never have a second to like look it up and be like, what are we talking about? My understanding, we are sharing, right? My understanding of this is that, you are, can this go away? No. My understanding of this is you're inhaling a steroid. What is a steroid? It's an anti-inflammatory. How does it work? It inhibits your immune system. If you are pushing steroids over your tongue, it's going to kill any of like, whether it's like the helpful bacteria, or it's going to kill the immune system of your tongue, which kind of seems kind of silly. But if that happens, The fungus that's naturally growing on your tongue is going to be uninhibited, and you're going to get thrush. So let's see like what Google has to say about that. Uh, See if I'm right with that. Yeah, prevent infection. Rinsing can help prevent a yeast infection. It doesn't even say, but that has to be why you do that. Okay. You can combine inhaled corticosteroids and a long-acting beta 2 agonist. And then you have something called like Symbicort, um, Advair, and Dulera. So these are going to be, kind of for more severe asthma. This is, yeah, it's like this, why not both? What's one option for this class three kind of chronic? I kind of made up these classes, but for the chronic, moderate, persistent asthma. We don't talk about these too much, but we just mentioned the leukotriene antagonist. This is going to be your montelukast singulaire. I've never heard uh, zafralukast ever. Theophylline is the big one. I don't know that anybody would ever use this, but the big thing that I feel like comes up on like the pack rat and stuff is that it causes um, what is M? Multi-atrial tachycardia? Is that what that stands for? Multi-atrial? It's the elevated version of wandering pacemaker, wandering atrial pacemaker. Yeah, multifocal atrial tachycardia. So that's the one. That's the big one you want to know about. What could theophylline cause? That's going to be multifocal atrial tachycardia or MAT. And you want to just fix the underlying cause, which is stop taking theophylline. Llamas, COPD only. I feel like these don't really come up. Tiotropium, you have like umeclidinium, vilanterol. There's also one called like Trelegy ellipta, which has like three things in it. But just knowing what categories, knowing you should rinse your mouth out, other stuff should be enough there. Asthma exacerbations, I feel like that never really comes up. Oh yeah, here's multifocal atrial tachycardia. These are just too big to fit. I don't know why I have. Oh, Theo for theophylline. I used to put little pictures here to help me remember. Like here's Spiro for Spiriva, Luke for leukotriene, Monty Python for Monty Lucast, whatever. I don't really use that stuff anymore. This is just more stuff on medications. Okay, that's it for asthma. It's really nothing too crazy. So this really, COPD is going to be chronic bronchitis versus emphysema. Knowing the difference between the two is going to be important. So we will take a short break and then we will talk about that. So what we could do is check mark. So they say that COPD, they say, I mean, this is what it is. COPD is really either chronic bronchitis or emphysema, or some combination of the two. Now, from what I understand, chronic bronchitis is more reversible, emphysema is less reversible because it has to do with wall destruction. But we'll start with chronic bronchitis because there's also acute bronchitis, which is a chronic, usually productive cough for 3 months out of the year for 2 consecutive years. So yeah, so this is it's right here. So reversible initially, bronchitis is just airway inflammation. Um, oh, I'm sorry. I'm defining chronic bronchitis, not acute bronchitis, which makes sense. 2 consecutive years is very chronic. Blah blah blah. Here's where the money is. So you get right-sided heart failure And this is core pulmonale, but I don't have that mentioned here, do I? Core pulmonale is an alteration in structure and function of the right ventricle caused by primary disorder of the respiratory system. So that is really what I'm describing here. Why is this here? Hypoxia and CO2 retention lead to vasoconstriction and pulmonary hypertension, then right-sided heart failure. This leads to edema and weight gain. Whoops. Core pulmonale is here. Right-sided heart. It's like remodeling, basically. I'm pretty sure. Yeah, because you have right-sided heart failure. You get that over time. It's going to be core pulmonale. It's heart remodeling from a pulmonary source. So you could look for JVD on exam. Yeah, multifocal atrial tachycardia. I don't know if that's a side effect or theophylline. I won't worry about that too much. Emphysema, on the other hand, oh, and then there's this idea here with the blue bloaters. They have this elevated hemoglobin peripheral edema. So they're circulating oxygen. I mean, they're circulating blood, but it's not oxygenated as well. That's why they're blue. And then they're bloaters, they're large because they have that heart failure, they have that edema. Now, on this side, emphysema, the path is all about elastase. Neutrophils and macrophages are going to release elastase in response to ongoing toxic exposure. You're going to have that alveolar wall destruction. So with wall destruction, well, that sounds pretty irreversible, and it actually is. When you talk about the alpha antitrypsin deficiency, which is in here under COPD, you are going to get more of the emphysema side of COPD. So tissue hypoxia leads to muscle wasting and weight loss or pulmonary cachexia. So you have tripoding here. So despite cachexia, you do get barrel chest. So they are cachectic, which means they're skinny and there's like wasting, but the lungs inside are large. You get the barrel chest. This guy over here in the blue bloater looks like he's barrel chested, and maybe he is a little bit, but you're going to see more of that classic barrel chesting over here in the emphysema side. And you're also going to get, you see like a squished heart. Generally, when you see this stuff, sometimes they don't get into the weeds. Is this emphysema? Is this chronic bronchitis? If you see any of this, COPD is going to be the answer. But if you have a more specific question, look for these differences. You'll get those distant heart sounds, hyperresonance, all because it is barrel chest. And then you also might get like a decrease in like electricity on an EKG because of that like barrel chest. I'm pretty sure. So yeah, so for emphysema, there is circulating oxygen, but there's just like less uh, like actual like cellular respiration going on. If I'm being honest, I don't fully understand it myself, but that should be enough. That should be enough. FEV1 over FVC is going to be the formula you want to look out for. Flattened diaphragm because of that, barrel chesting. It's going to, trapped air is going to flatten the diaphragm. That's big. Flattened heart from barrel chest. That's big as well. Retrosternal air. It's all air trapping, all air trapping. Global Initiative for Chronic Obstructive Lung Disease. So global obstructive lung disease. That's kind of a stretch, but just know that that has to do with COPD. That's how you stage this. There's all these risk factors, not worth knowing in my honest opinion. Just know as you get higher risk, you're going to break out steroids. You're going to give them steroids. So whereas asthma was more of a viral infection, COPD is going to be more of a bacterial infection that is going to exacerbate that. This is just asthma versus COPD, whatever. So since bronchitis is on here, I think we talked about that here. So here's acute bronchitis. And I put this versus bronchiolitis. So acute bronchitis, normally well appearing, normal vitals, usually viral, right? This is usually going to be a complication from a cold, RSV, coronavirus, flu, parainfluenza. Doesn't really matter the cause. It's just if you have a patient presenting with this, don't give them antibiotics because it's probably viral. You're going to have a persistent cough, and usually it clears. You're going to have rhonchi, which clears after coughing. That's kind of like the hallmark finding here. Bacterial causes are going to be so mycoplasma and chlamydia, those are atypical bugs, and then Bordetella pertussis, that's going to be gram negative. Sputum. The interesting thing in here is if somebody comes in, they say, I have this lingering cough, I have this viral URI, this cough won't go away. You can actually give them a SABA. So even if they don't have asthma, you can actually give them albuterol to help them with the cough. Who do you want to give antibiotics for? COPD exacerbations. These are high risk patients if they're COPD or if they're immunosuppressed or if they're old, like greater than 65, then you can give them an antibiotic. And I don't think it matters. If these are the bacterial causes, you want to use something that covers atypical bugs. So you'd probably want to give them like a macrolide, which would cover that. And then you could give them like, I mean, Bactrim and azithromycin, I think, are both options for pertussis. Something like ceftriaxone will kill all your gram negatives as well. So whatever, but you probably just want to make sure you cover your atypical bugs. Is any of this stuff on here? Bronchiolitis? I don't see it, honestly. So if I don't see it, I'm not going to worry about it. So we're going to call these checks bronchitis, COPD. Okay, well, not too bad. We're actually going to move right on to tuberculosis is here, so that's under infectious disease. So we could talk about TB a little bit. And then the fungal? Oh, fun. We'll talk about the fungal pneumonia. Not technically on here. One of them is, which isn't really talked about in these. This is more talked about in like the typical pneumonias, but we could talk a little bit about tuberculosis. Oh, geez. All right. We'll talk about that in a minute. Okay. You use an acid-fast stain for tuberculosis. That always seems to be like a buzzword thing. Let's see. So a palpable induration. Remember, you want to measure the induration, which is the total like area. So greater than 15 millimeters will be positive. You always want to look for risk factors, right? If you have risk factors like you're foreign-born, IV drug user, you get less to get away with. So greater than 10 will work. Very immunosuppressed, like HIV, or you've been around with somebody with TB, greater than 5. So it's just like the 5, 10, 15 rule. Treatment always going to be important, and we'll go over. You want to know the side effects of these. So it's RIPE, so it's rifampin, isoniazid, pyrazinamide, and ethambutol. Ethambutol is going to be you can look at the O at the end here. So that's for optic neuritis. Rifampin is like riffing over a liver, so that's going to be hepatitis. Isoniazid is think about Star Wars when Darth Vader came out and Luke is like, I, son. And then Darth Vader does like force lightning on him. So that's going to be seizures, I believe. And then pyrazinamide, I don't remember that one. We'll go over that one in a second. Might be something like urinary. Gone complex, another big buzzword. Central caseation necrosis, another big buzzword. That's all going to be tuberculosis. It can be latent and reactivation. TB is going to come at the apices of the lungs. If there's bones and joints, like in you can get like thoracic, like curving, or it's like a mass or something. That's called Pott's disease. Miliary TB are the seeds all over the X-ray. And then if you have it up in your lymphatic system, it's a neck mass. It's called a scrofula. I did have this memory pal. So rifampin is the hepatitis. Isoniazid are it's intractable seizures, peripheral neuropathy. Yeah, so it is. So it's hyperuricemia with pyrazinamide. I think about like PYR, like a pyro, and you need a P all over it. Um, which really isn't what this is. This is uric acid in the blood, but whatever. Ethambutol is going to be your optic neuritis there. Is there anything else with TB? It's not that bad. Once you have a positive test, you'll be positive for life. So there's no reason to do a PPD if you've already had a positive one. This IGRA, and you'll see the quantiferon gold. That's going to be another good test you can use. Yeah, whatever. I think that's enough probably for TB. Bold these. Let's bold these. So we're going to move on to pneumonia. All right. So pneumonia gets a little bit crazy. And you'll see pneumonia come up through obviously infectious disease. You'll see it in pulm, H&P will get it, and then you're just going to see it a lot. What you'll learn is that these three bugs, strep pneumo, H flu, and MCAT, are the three causes of typical community-acquired pneumonia. What does typical mean? Well, strep pneumo is gram positive, H flu is gram negative, and MCAT is gram negative. It means these are common, but it also means, they have a biological structure that we can target. They're either gram positive or they're gram negative. When you hear the terms atypical, what this means is we say lack of cell wall, not exactly, because like some of these technically are gram negative, but just remember it's Mike's clam legs. You want to remember Mike's clam legs. This is a mnemonic I still use to this day, are the atypical bugs. Atypical just means there's something weird about their biology. There's something weird about the way that they're structured, that they don't exactly fit in to the bucket of gram positive and gram negative. Why that's important is they can present with unique symptoms because of the way that they infiltrate through the body. But more importantly, we need to target them with specific antibiotics. Okay. And the three antibiotics that treat atypical bugs spell either FAT or FAD. And the F stands for fluoroquinolones. There's your fluoxetins, ciprofloxacin, moxifloxacin. A is azithromycin, so that's going to be our macrolides, azithromycin, erythromycin. And then the T can either stand for tetracyclines or D, which would be doxy. So three really important antibiotics to know, and those are going to target Mike's clam legs. Those are your atypical pneumonias. I don't know why I put walk. I honestly don't know what walking pneumonia is. That's not really a thing that we use. Okay. Yeah, generally these are more of an insidious onset. It's a non-productive cough. It's a low-grade fever. You're going to get more interstitial infiltrates from typical, more rapid, more kind of like the flu, more productive cough. It's not common for people to have like a non-productive cough when they're really sick. So you think productive cough more with typical and then lobar infiltrates versus interstitial. Flu, whatever. So there's our strep pneumo, our H flu, our MCAT. You can do a urine antigen for strep pneumo and for Legionella. That's always a good thing that comes up. Then there's a bunch of other than H flu, strep pneumo, and MCAT. The other community acquired bugs are Klebsiella. All right, Klebsiella is gram negative. Buzzword here, current jelly sputum, done. Pseudomonas, also gram negative. Opportunistic. You're going to treat for this if somebody has like if they step on a nail and it goes through like a dirty shoe, you're going to see this in like soil. Diabetics are at risk for this, but then cystic fibrosis as well. This is an opportunistic infection for patients with cystic fibrosis. I think you can get this in like the HIV population too. You have MSSA and then the more serious MRSA. Staph aureus is gram positive. You have group A strep, that's gram positive, and then pneumocystis jirovecii, which technically is fungal, but it's in this group because it can cause pneumonia. That's on here. Use sulfonamides, which should be Bactrim, yeah. Bactrim is the treatment for that. That's just something you have to memorize. I have some weird memory palaces for this. I don't know that it's worth getting into those. Where is infectious disease? That should be here. I think sulfonamide is. Yeah, because it's trimethoprim, sulfamethoxazole. So I'm pretty sure. Let's see. Is this Bactrim? Are there examples? List of sulfonamides. Sulfamethoxazole. Yeah, yeah. Okay. Community acquired pneumonia, atypical, likes clam legs. Legionella, the big thing here is relative bradycardia. That's always something that comes up. Mycoplasma, you're going to see more in like school, college students, military recruits. You could see erythema multiforme. My memory palace and stuff. Let's get to treatment for this. A healthy outpatient adult without a comorbidity, we hit amoxicillin. So we just hit them with a gram positive killer, uh, you know, a penicillin. Comorbidities, we need to get a little bit crazy. Augmentin, I believe. Now, I know I mentioned FAD and FAT, but I'm pretty sure. Oh, never mind. So this is going to be our gram-positive killer. It's a penicillin, but with a beta-lactamase inhibitor. Um, but we still need to add in a macrolide. Why do we need to add in a macrolide? Because it covers atypicals. Um, Augmentin or cephalosporin, you just pick one. You would probably do like a Keflex, a first gen, if you want to cover gram positives here, and then you hit it with macrolides. Um, or instead of a macrolide, you can put in doxy. So just have atypical coverage, or you just hit them with a fluoroquinolone, which is going to cover like everything. Probably more gram negatives. This will work for us. It's like good for Pseudomonas. This is good for Legionella. If you're inpatient, again, pick a beta lactam, pick a penicillin, augmentin. That's what this is. Yeah, augmentin. Same thing. So, or beta and doxy, or just a fluoroquinolone. If they're in the ICU, again, beta lactam and fluoroquinolone. Jeez. Staccato cough is going to be chlamydia. Aspiration pneumonia, you want to use, what's that, unison, ampsulbactam. Same for lung abscesses. Yep, unison. Always aspiration pneumonia. Look for like risk factors, decreased loss of consciousness, decrease. This is really like altered mental status. altered mental status, dementia, actually. Number one cause of death is aspiration pneumonia. Pretty interesting. Parkinson's, anything that kind of inhibits the airway, inhibits swallowing. Okay, fungal pneumonias this is like classic pack rat stuff here. There's a really good mnemonic for histoplasmosis from a colleague of mine about his toe. So you think of a bird pooping on his toe. This is all in the Mississippi, Ohio River Valley. Think about like the history. I always think about like the Susquehanna River, River of Dreams, a lot of history there. Mississippi, Ohio River, a lot of history up and down. Mark Twain, whatever. So think of all the history. This is going to be birds pooping into the soil, and this like gets all up into you. There's other stuff, chicken coops, those are birds. So that's all histo territory. Coccidioid mycosis. This is going to be more in Arizona, the Grand Canyon. This is from like military maneuvers. I always think of like Tony Stark and all of the like dust that's blowing up as he's blowing things up in the desert. You get all these skin rashes with this as well. Cryptococcus, I feel like these two aren't tested as much. Aspergillosis and this fungal ball with this like not so classic triad. I mean, hemoptysis definitely jumps out. So if you see hemoptysis, go with aspergillosis. And then Cryptococcus has some like CNS symptoms. Again, I don't feel like it's life-threatening fungal infection in the HIV population. I feel like that didn't even come up when we talked about HIV. But knowing the difference between histo and coccidio, see anything in the Mississippi, Ohio River Valley, go histo. If you see anything around Arizona, Texas, Grand Canyon, it's coccidioid. And that should be good enough. Uh, I think that's it for pneumonia, honestly. Bactrim for Gyrovici. Let's knock out the restrictive lung diseases real quick because I feel like those aren't terrible. Where was that? Here. These aren't terrible. Yeah, so restrictive lung diseases, there's two types. There's intrinsic that have to do with the alveoli and the interstitium, and then there's extrinsic, which have to do with like the nerves. So extrinsic is going to be myasthenia gravis, Guillain-Barré, but then there's also like asbestosis. I always got confused with this, honestly. You have alveolar, you have interstitial. Sarcoid is over here, it's restrictive. These are going to be problem getting air in. So it's almost so restrictive. I have a snake here because it's like a boa constrictor around your chest. And it inhibits you from actually taking a deep breath in. You can get air out just fine, but you can't get air in because your lungs are literally getting crushed. With COPD, your lungs get larger, there's air trapping, but with restrictive lung disease, either because there's neurogenic causes and you just can't breathe in all the way, that something's wrong with your diaphragm, or there's just other stuff going on in there that is restricting your air from actually coming in. So what else is important here? Sarcoid, erythema nodosum is a huge one that comes up so many times for sarcoid. An ACE level is going to be inhibited. You have the stages of sarcoid, have never gone through that at all. Isn't it just like steroids? Yep, IV steroids is going to be the treatment, or you can use these are like stronger immunosuppressants. You'll see these in rheumatology, methotrexate, azathioprine, not as much, but it definitely comes up. Velcro crackles, asbestosis, silicosis. These are all these pneumoconioses. Yeah, then you have these four like types of reactions. One is allergic anaphylaxis. It's like this ABCD. Pulmonary fibrosis. Here's some more extrinsic stuff. So you have pleural effusions because that's it's fluid in the pleural space and it's filling up. It's pushing your lungs upward, so it's reducing the amount of space there. Myasthenia gravis, which is going to be you're going to get like facial weakness, but then you'll also get like proximal muscle weakness as well. So I think just weakness in general. You're going to get thymomas on chest x-ray. So the thymus, so this is a huge thymoma, I'm pretty sure. So if you have something in your mediastinum, in your thymus that's pushing up against your lungs, that's definitely going to restrict your breathing as well. Guillain-Barré is, of course, going to be that ascending paralysis. ALS, some anything that's going to prevent you from breathing. Kyphosis, scoliosis, any type of orthopedic issue, bending over either this way or this way. And then obesity Pickwickian, which is this obesity hypoventilation syndrome. Sleep apnea, honestly, we never really learned about. There's like a lot of risk factors and stuff. Wear a CPAP. This isn't too bad. I mean, obviously, I'm going very surface level. I guess we could knock out malignancy real quick. That was on this. I think the big thing for this is non-small cell versus small cell. Small cell is going to be oat cell cancer. Number one type of, so 85% of all primary lung cancers are going to be non-small cell. Adenocarcinoma starts with the letter A. That's going to be the number one type. It develops peripherally. Think of A for A around the outside. Squamous cell carcinoma, so SCC, is going to be centrally located cavitary lesions. And these are going to be your mouse pearls. So yeah, think of like a Mickey Mouse like pearl necklace. Um, and that's going to help you remember squay mouse and keratin pearls. So that makes that little connection. What are those keratin pearls? They're pearls of keratin, but you also get hypercalcemia. This is a big one. You'll learn about this in HEMONC. So tumor lysis syndrome can cause a lot of electrolyte abnormalities. The way to prevent this is just hydration. So you want to do hydration. Smoking is a big risk here. So non-small cell more commonly. Okay, then you have like all of these, what is it called? You have these paraneoplastic syndromes, so around cancer. So you have all these weird things that can occur. You have hypercalcemia. You have, and I think that's because this stuff mets to the bone and then your bone starts breaking down. It's like multiple myeloma and stuff. SIADH, so ADH is your antidiuretic hormone. So if you have an inappropriate amount of that, you're going to retain fluid. So fluid retention, and then you're going to get kind of that relative hyponatremia. Can also get Cushing's. And I think too, because a lot of these cancers, start like pushing out cortisol. They just start pushing out weird stuff. Trousseau syndrome, this is like a thrombophlebitis. Hypertrophic osteoarthropathy. Eaton-Lambert is a big one. That's kind of tied in with myasthenia gravis. Cushing's, you're going to see moon faces, buffalo hump, hypernatremia, hypokalemia. I think that's because aldosterone is increased as well, possibly. Same type of stuff here. Then there's carcinoid tumors. You get serotonin syndrome, altered mental status, muscle rigidity, autonomic instability. Just a really, really good triad to always know. ACTH, so this is more of the Cushing stuff. You can get insulinomas, ectopic insulin production. Then there's nodules, pulmonary nodules on here. Yes, technically, 8 millimeters is a good threshold to look at here for low risk. Surgical resection once you get over 20. So 20 is a nice, easy number to remember where you need surgical intervention. That's most of this, honestly. Pulmonary embolism is like easy enough. You kind of get over it in P2 year a little bit, unfortunately, but you're thankful you don't have to dive that deep into the details. You kind of hope that you're going to remember most of the big stuff, pleural effusion, pulmonary nodules. I don't even remember where pulmonary hypertension came up. Is it here? Can be primary or secondary, normal mean pulmonary. So this is the pressure just in the pulmonary artery. Normal is 9 to 17. So kind of what intraocular pressure is usually like between 10 and 20. So kind of the same there. To actually get the measurement, you have to put a catheter into the heart and actually measure it. That's definitely something important. Honestly, I'm satisfied. So there's a little quick crash course on pulmonology. Is there anything else? I don't think so. I mean, in general, just know your antibiotics. This is my little chart here. So atypicals are going to be your rainbows here. So remember it's fat. So fluoroquinolone, A for azithromycin or macrolides, and then T for tetracycline or D for doxy. Um, and then you have to think about this too. These are the cell wall inhibitors because of the weirdness of the atypical bugs. You need to break out a protein synthesis inhibitor, or I think this is like a folic acid, oh no, a DNA replication inhibitor. Some of these can cause C. diff. I feel like that's not that important. The other thing too is with MRSA, there's this idea that mnemonics, if you can store your mnemonic in a place, obviously I'm a huge proponent of memory palaces, but I tried to come up with all of these different mnemonics for what antibiotics cover MRSA. And I finally hit one, which is this, because I use the letters MRSA to help me remember. There's four antibiotics and there's four letters of MRSA. So how I remember this, these are actually out of order. Um, how I remember this, the letter M, if you look right in the middle, is you could fit a V in there. There's Vanco. R, I think of like this first vertical line of an R being like somebody's back, and this kind of being like a ponytail with hair coming down, or like a long hair growing out of your back that you want to trim. S, the little loops of the S, if you turn it to the side, make it like a light cycle from Tron or like a bicycle. A cycle always makes me think of doxycycline or tetracycline. I feel like I say that weird. So that always helps me remember doxy or tetra. And then A, I think about Abraham Lincoln or just any president like Clinton. So think about all the presidents here. So Abraham Lincoln makes me think of the lincosamides, which the only one we really talk about is Clinda. That has worked for me. I have recalled that in small groups. I've recalled that in the emergency room. Just writing down those quick letters or four letters or thinking about those letters has always helped me. I tried to come up with all these other things, and then um, fat or fad is just something I memorized. So you could even think of like fat, fade, typical. The Coumadin ones, I don't really care about. Fluoroquinolones and macrolides for prolonged QT. Those for me just stuck after a while. The other thing to know about clindamycin is that it covers anaerobes, other than Flagyl, and then like the crazy stuff like your Zosins and your Unisins. Clindamycin and Flagyl are the only ones that cover anaerobes. So you're going to see those a lot in GI issues. You're also going to see them a lot in the treatment of like peritonsillar abscesses, stuff in the back of the mouth. You're going to see either Flagyl or clindamycin used for. You see doxy used a lot too, but whenever you need anaerobic coverage or whenever you see a regimen that includes Clinda or Flagyl, it's because they're covering anaerobe. So antibiotics definitely a good thing to know. And I think that's it. I think that's all I have for this one. So see you in the next one.